Hello, this is our lecture number 32, and we're going to be talking about what's called the Diagnostic and Statistical Manual. You'll see the acronym DSM, and a little bit about how we go about defining abnormal behavior. And I think for many in a survey course like this in psychology, you come in with a lot of preconceived ideas and notions about the nature of mental illness. And for many, I think that this is what they associate with psychology is the study of mental illness and the helping professions that have to do with assisting those individuals, the treatment of mental illness. So again, this is an important area in psychology, certainly not the only area, but one that for many of you, you might want to consider taking a class later on in the study of abnormal behavior, which is a semester-long course. Again, we can't really get into things in too much depth, but I want to give you some background. And hopefully that background will be helpful to you and might even stimulate you to take other courses in the field of psychology that have to do with abnormal behavior. So I like to start this out by showing a now iconic painting. And this iconic painting was one that was painted by Edvard Munch. It's called The Scream. It sold a few years back for $120 million, and for many, they have described it as, the face really of the study of mental illness, the face that launched 1,000 therapists. Edvard Munch never let on to what this painting actually represented, but it really has been adopted by the clinical psychology community. You will see it hanging in the offices of many clinicians. You will see it in many textbooks, introductory psychology textbooks, textbooks on the study of behavior disorders. And even though Munch never let on as to what it actually meant, it is thought to represent the inner anguish that individuals experience and feel that are suffering from mental illness. So again, it's an iconic painting, and it is one that once again is thought to represent this extraordinary anguish that people suffering from mental illness experience. So that being said, what I try to do to introduce this is have you engage in a little pretending, pretending that you're a psychiatric social worker, and that over the course of a day you have 3 patients. Patient number 1 is a man that has an IQ of 50. You know this to be 50 IQ points below the norm. And you have been trying to help this individual actually for a number of years. When you think about this individual, who once again is 50 IQ points below the norm, of 100, you also think about you're in a large psychiatric institution, let's say, and just down the hallway from you is the office of a very famous surgeon at the hospital that you're at, and that surgeon has an IQ of 150. And you would never consider that surgeon to be abnormal. Yet you would consider this man who has an IQ of 50 points below the norm, you would consider that man to be abnormal. So it causes you to think about what is normal and what is abnormal. How do we define it? Who defines it? So that's patient number 1. Patient number 2 is a 55-year-old woman. She's planning to marry a 23-year-old man. And this is an individual who's less than half the age of this woman, and she has been encouraged. This woman has been encouraged to come to you to speak with you. She's been encouraged to come by her daughter. And again, she plans to marry this man who is much, much younger than she is. And you begin to, again, think about your own past a little bit, and that you had a 60-year-old uncle who married a 30-year-old woman. And no one really thought about that as being too unusual. But yet, with this woman who plans to marry a man half her age, some in your family consider this to be abnormal. So again, what's normal, what's abnormal? Who defines it? How do we go about defining it? Patient number 3 is a man that's been diagnosed with schizophrenia. He comes into your office. He is in a straitjacket. He's accompanied by 2 attendants. He's an individual that has been in your psychiatric facility for a number of months now. And this individual proceeds to now take all of his clothes off and climb up on your desk and sit on your desk in Indian style. And arms folded, legs folded, and simply sits there and looks out the window and makes absolutely no contact with you at all. And as you think about this individual and what you're going to do to try to help this individual, you think about some courses that you took when you were in college. And those courses had to do with various religions, Eastern holy religions, for example. And you recall one individual, Gandhi, who had millions and millions and millions of followers. And Gandhi would spend months of his time in seclusion, in meditation, and his behavior had very much the same appearance as that man who is now sitting on your desk that's been diagnosed with schizophrenia and who probably will be in some kind of an institution maybe for a lifetime. And you contrast that with Gandhi, who was revered by millions of people, who in many respects had a lot of the same behaviors as this schizophrenic individual. How do we go about evaluating who's normal and who's abnormal? And I think that these 3 cases really exemplify the problems in this area in terms of making those incredibly important life-changing decisions about mental illness and who is mentally ill, and who's at risk, for example, to society and so on. So again, I want you to think about that, as we go along. And, defining normal and abnormal, I think that's, an incredibly important topic here that we all need to reflect on. Not only now, but certainly periodically over the course of our lives. When we take a look at medical sciences and how medical sciences go about defining normality, they simply say that it's the integrity of structure and function of an organ or other body part. That seems really easy. The line is very easy to draw. They give you some examples. On a nice day, you're out playing, let's say, a pickup game of soccer with friends of yours, and all of a sudden you step into this hole that's in the field that you're playing on, and you can feel this pain shooting through your foot and up your ankle, and you can't walk. Your ankle now is puffing up, and your friends help you out. You get to a hospital, you have an x-ray, and the x-ray shows that you have a fracture of your ankle. So the doctor puts you in a cast after you're on crutches for about 3 weeks. Then you go back again. You're recasted and put into a walking cast. You're in that for another 3 weeks. Then you go through 10 weeks of physical therapy, and then you're as good as new. Again, the line is easy to draw between what's normal and what's abnormal. You have individuals, for example, that are diabetic. You do a blood test and or a urine test, and you can find out right away whether or not that individual is a diabetic. Now, again, the line is incredibly easy to draw. Not so easy to draw in the case of behavior and behavior that's not normal. Okay. So when we take a look at this in the context of psychology and trying to define normality, there's 3 different ways that I want to try on for size that might help us to do this. One is something that's called the statistical criterion. The second is what's called the ideal mental health criterion, and the last one is what we would call the clinical criterion. And let's take a look at each one of those and see where it gets us. The statistical criterion is saying this. Very simple. What most people do is normal. Any deviation from the majority is abnormal. Well, that seems like a good way of doing things, But think about that for a few moments. Think about it in the context, for example, of potential drawbacks. The statistical criterion is specific to time and place. Consider, for example, if you were down on Jones Beach, down in New York, beautiful beach in the summertime, and you were down there, let's say in 1920. And in 1920, if you look at what women were wearing for swimwear, it was they were very covered up. They were all, in one-piece bathing suits. And again, very much covered up. If you go down to Jones Beach today, right, what you see is very different from that. What you see is, many women wearing relatively skimpy bathing suits, 2-piece bathing suits, for example. That's now the norm. What was the norm back then is not necessarily the norm now. Consider also what marriage looks like in some other parts of the world, where in India, for example, there are arranged marriages. You know who you're going to marry when you're about 10 years of age, because it's all been arranged by families. I mean, that's not something that would really work here and in many other countries. So again, this is something that's specific to time and to place. But more importantly, it doesn't distinguish between desirable and undesirable deviations from the norm. All it says is what's not at the norm, right, is abnormal. So, for example, that very famous surgeon down the hallway from you that we described earlier, that's brilliant, has an IQ of 150, 50 IQ points above the norm, absolutely brilliant person. By our definition of statistical criterion, that person would be considered to be abnormal. Well, there are some deviations from the norm that are very positive, and certainly that's one of them, right? But the statistical criterion doesn't allow us to make those distinctions. So that's something that we have to think about seriously. And the statistical criterion doesn't really help us all that much. Another criterion that we can take a look at is one that we call the ideal mental health criterion, where we say normality is a goal or ideal that an individual strives for. Well, think about this for a few moments. Think about it in the context of what different theorists say the ideal mental health criterion is. Carl Rogers says that it's self-actualization. Getting to that, a place where you're having a peak experience, where you're really, more aware of space and time than at any other point in your life. It's a rapturous period, of your life. That's how Carl Rogers would define it, the ideal mental health criteria in terms of self-actualization. If you self-actualize, then you're normal. If you haven't, then you're abnormal. Eric Fromm, another important psychologist, would say that's productivity in your life. being productive in the job that you have, being productive in terms of your life's work, for example. Eric Erickson, on the other hand, would say, well, it's integrity. It's living your life, a purposeful life in terms of your character and the integrity of your character, right? So again, it differs from theorist to theorist. So the ideal mental health criterion, that really doesn't work too well for us either, right? So let's try and emphasize this last one. It's called the clinical criterion. What we say is, it's really the absence of abnormal symptoms. It's the amount of subjective unhappiness that you may experience or social maladjustment that you may experience in your life. Well, I tell you what makes me subjectively unhappy. What makes me subjectively unhappy, for example, is when my favorite baseball team, the Boston Red Sox, don't do very well. Or my favorite football team, the New York Giants, that they don't do too well. For you, this subjective unhappiness might be, well, maybe, you've been having a tough time trying to get a job, a summer job, for example, or a part-time job. That could make you unhappy. Or maybe you're having a problem with a roommate. That makes you subjectively unhappy. Or maybe you're having a problem with your parents. That makes you subjectively unhappy. When we examine this clinical criterion, there are also drawbacks to it. Again, we get into this whole area of how individual clinicians interpret subjective unhappiness. And indeed, they may differ from one therapist to another therapist in terms of how they go about defining this. But more important than this, it really treats psychological disorder like it's analogous to physical disease, which it is not. You cannot cure, for the most part, psychological disorders in the same way in which a medical doctor cures disease. It just simply doesn't work that way. Okay, it's a far more complex kind of endeavor. So again, when we make comparisons to the medical profession in terms of normality and what normality is, and hence what abnormal is, again, the line is relatively easy to draw. In the case of psychology and the assessment of behavior, it's not so easy. So we've tried these three different tactics, these three different ways of defining normality. In each one of them, there's certainly drawbacks. So where do we stand? If you read one book in psychology other than your textbook, I would encourage you to read this one. It was one that was written a number of years ago by Thomas Szasz. It's simply called The Myth of Mental Illness. And in this book, Thomas Szasz says, mental disorders are problems in living. And he believes that in the final analysis, it's not going to be a therapist that's really going to help you. It's really going to be you. It's going to be the person, himself or herself, who encounters this problem in their life. This is a very radical way of viewing mental illness, that it is a myth. He says we're making up words all the time to describe people who are different. Words like schizophrenia, for example. And that really allows us to assign these labels to these individuals, and it allows us to lock them up, sometimes for life. And a lot of it's because we just don't really understand these people. If you take a look at this quote, which I think really captures this dilemma so well that Thomas Szasz has written about. He says, mental institutions are a place for people that you really don't understand, you really don't care about, and you really have little compassion for. Unfortunately, I think that this is very much the case, even today. We've come a long ways in terms of making improvements with, a lot of these dilemmas that we have in terms of mental illness. But again, Thomas Szasz says it's really a myth. Mental illness is a myth, he says. So, this is a very interesting way of approaching things, not universally accepted, by the way, but one that still challenges the field of psychology and psychiatry. Let's take a look at a very famous study. And again, there's I think several videotapes that you've been assigned to look at that will, in whole or in part, describe this fascinating experiment that Stanford psychologist David Rosenhan conducted a number of years ago. It's a very clever study, and it's really all about what happens when you label an individual as being mentally ill, and how difficult it is to shed that label. So here's how the experiment goes. He and some of his associates have themselves committed to a mental institution. And what they do is they complain to the psychiatrist or psychologist that's seeing them. Again, they're doing this all, surreptitiously, that they hear voices. And those voices are saying empty, dull thud. That's all. That's the only thing that they describe. And they're admitted to these hospitals. Again, these individuals are in different regions of California, and they're all colleagues, people that Rosenhan has worked with in the past. And so they do this experiment where they're admitted. And again, the only symptom is this. They say they're hearing voices. They complain that they're hearing voices, and the voices are saying empty, dull thud. Once they are admitted, they start acting normal, but nobody really notices. Nobody really sees that they're acting normal. And indeed, this is something that goes on for an extended period of time before they are finally released from the psychiatric institution that they've been admitted to. So their sanity was not detected, but they were eventually released. And on their release forms, it says in remission. Now, being in remission is very different than someone writing up on a report saying you're cured. This is a label that sticks with you for the rest of your life. And indeed, labels are incredibly powerful. They profoundly affect, information about you, how that information is processed, how it's perceived by other individuals. These labels stick forever. So indeed, between Rosenhan and Thomas Szasz, I think that they illustrate the flaws in how we've gone about treating those individuals who are different, those individuals who are suffering from mental illness. This is where we get into, how we go about conceptualizing this whole difficult problem of differentiating between normal and abnormal. And I think that in the field of psychology today, psychiatry as well, we really talk more about adjustment, the concept of adjustment. And understanding this concept of who's adjusted and who's maladjusted is something that I think is a little bit easier to work with. So, for example, the reason for doing this is that we want to get away from a fixed ideal that a therapist has, that that therapist may impose upon that individual. There are four main areas of adjustment. There's physical adjustment, psychological adjustment, social adjustment, and moral adjustment. And let's take a look at each one of these a little bit so that we understand these four basic dimensions, okay, adjustment. So, for example, who goes about defining adjustment? Certainly, physicians define it in terms of physical disorder. The courts define it in terms of social maladjustment. The clergy defines it in terms of the moral realm, and psychologists and psychiatrists define it in terms of behavioral maladjustment. So, for example, I mean, in physical disorder, it's the integrity really of bodily function. That's how we go about defining maladjustment. The courts are defining it in terms of, has this a person, or is this person one that his or her level of adjustment is so lacking and is a threat to other individuals that this individual should be confined for a period of time. When we take a look at the moral realm, we're really talking about the clergy defining maladjustment. And psychologists and psychiatrists are defining behavioral maladjustment. A person's constantly asking themselves, what form of adjustment is appropriate for me? And again, psychologists and psychiatrists are defining whether or not that level of adjustment is one that is appropriate for that particular individual. So again, we talk about adjustment and maladjustment as opposed to talking about mental illness, right? So again, this is an important concept. And again, defining maladjustment, I think in general, clinicians will apply that label of maladjustment to a person who's generally uncomfortable in terms of their living. They're unhappy, unhappy with their inner life. They'll have a lot of difficulties with interpersonal relationships. They have difficulty, excuse me, performing any kind of tasks that are expected of them. And there's also a level of understanding that certain behaviors are what we would call bizarre, okay, and behaviors that simply don't allow that individual to live a comfortable life. So I think this is how clinicians generally would proceed in terms of this whole concept of what is adjusted and what is maladjusted behavior. So how do we decide upon these things? How does a psychologist or psychiatrist? Well, clearly a lot of formal training, academic experience, practical experience. I mean, clearly this is very, very important. Clinical training programs, doctoral level clinical training programs. I look at our own program at the State University of New York. It's very intensive. A lot of academic courses that one takes, a lot of practical training that one takes. A clinical training program these days is in the neighborhood of about 5 to 6 years, and it's more difficult to get into a clinical psychology training program than it is to get into medical school. Clearly, an enormous amount of practical experience is needed over the course of this training. There are internships, for example, that have to be taken. There's state licensing examinations after you've received your doctoral degree and gone on internship. You have to learn about interviewing techniques and diagnostic tests. An enormous amount of time is spent with that. And how to utilize what's called the DSM, the Diagnostic and Statistical Manual. So again, this is, these decisions are being made by professionals. Professionals have this enormous formal training and experience that's very intensive, very rigorous. These are individuals then who become well equipped to be able to make these life-changing kinds of decisions. So we talk about the Diagnostic and Statistical Manual of Mental Disorders. It's now in its 5th version. And this is really a guidebook. This is what helps us in terms of making these all-important kinds of decisions. So it is descriptive. It's not explanatory. It's not based upon any particular theory. Okay, it's all evidence-based, we say. And by that, we mean that the latest research drives the revisions that are made usually every 5 to 10 years. Again, when we take a look at this, when we take a look at how we go about diagnosing a particular behavior, the DSM is providing us with this direction. And keep in mind that what the DSM does is for, all the various behavior disorders, we need to know about the symptoms and the number of symptoms that an individual displays. We need to know about the duration of those symptoms, how long or how short are they, and we need to know about the severity of the symptoms that an individual is experiencing. So again, any diagnosis based upon symptoms, that's how we do it. The DSM gives us direction in doing it, and again, it's the number of symptoms, the duration of those symptoms, and the severity of those symptoms. That's what drives this. So there's what we call the 5 axes of the DSM. This is being modified now a little bit in terms of the most recent version of the DSM, but it's still, pretty much the same. There's axis 1 that we call clinical disorders, and it's really all the various mental disorders, and with the exception of like personality disorders and mental retardation, also cases of abuse and neglect, but all the various clinical syndromes. That's axis 1. Axis 2 is personality disorders and mental retardation. These are lifelong disorders, deeply ingrained, where individuals are experiencing these for very, very long periods of time. Axis 3 is what we call the general medical condition of an individual. There are medical conditions, certainly, biologically based conditions that can affect a patient's mental state. And then axis 4, what we call psychosocial environmental problems. Certainly, there are many behavior disorders that are a result of stressful events in a person's life. And these things can be long lasting. And then lastly, this axis 5 is called global assessment. How generally is that person functioning? How well are they engaging in terms of their community, their family, the jobs that they have, social situations. So again, the DSM drives our decision making in this area. So what we will do in our next lecture is we'll take a look in a little bit more detail at this classification because it does help us a great deal in terms of making these very important distinctions about who is adjusted and who is maladjusted. So we'll take a look at that in our next lecture.